Welcome to our webinar. We're going to get started shortly, but first, a little bit of housekeeping. Submit your questions at any time. I have a bit of a conflict of surgery that was scheduled right after the webinar, so we will do our best to answer all your questions in one of the formats that's noted here, and we'll get you the contact info as well. Hi, I'm Dr. Steve Vasilev, and I'm your host and presenter today. Those letters after my name are not for bragging rights. They're basically there to give you a little bit of a story of my background, and that is that I'm a gynecologic oncologist, board certified, traditionally trained, and a robotic surgeon. But also, on the other side, I'm a fellow of the American College of Nutrition and board certified in integrative and holistic medicine. So I'm hoping to give you a little bit of a unique perspective on ovarian cancer and treatment thereof or prevention. So today we're going to talk about ovarian cancer and what it is, how does it occur. We're going to talk about prevention strategies, screening strategies. We're going to talk about treatment advances in surgery, chemotherapy, biologics, etc. And as mentioned, the integrative perspective. So molecular integrative oncology, how that impacts nutrition specifically, and lifestyle modification and things of that nature. So in short, I'm hoping to give you a little bit of an overview of how we go beyond the state-of-the-art at St. John's. So where does ovarian cancer arise? Obviously, there are two ovaries. And when you look at the microanatomy, the most common arises from the surface, and that's what we're going to be talking about today. There are different cell types, but it's different from the germ cell or sex cord stromal tumors, which usually occur in younger women. Today, we're going to focus on the epithelial ones. Ovarian cancer in general is very uncommon, only 1.5% lifetime average risk without a gene mutation, and 80%, in fact, are sporadic and not gene mutation based, at least not based on inheritance of genes, and I'll talk about what I mean later. Ovarian cancer is only 3% of all the women's cancers in the United States, and the overall survival, unfortunately, because of late-stage diagnosis, is less than 50%. Risk factors include postmenopausal age, family history of various cancers, specifically breast, ovary, prostate, and pancreas. Gene mutations definitely increase the risk, such as the Angelina Jolie story, Ashkenazi Jewish descent, never given birth, infertility, we'll talk about why in a bit, and toxins such as the talc story and others. Back in the 80s when I trained, the problem was that there was really no screening tools available. BRCA screening only became available in the mid-90s. And Gilda Radner, the star of the original Saturday Night Live, was diagnosed in late 1986, and by early to mid-1989, she was gone. There were months of fatigue, in her case, almost a year. Advanced diagnosis, stage 4 in her case. Large surgery, ICU stay, pretty intense therapy, very few effective chemotherapy drugs back then, and less than a year of remission was norm, so death occurred within about 6 months of relapse, so she did actually pretty well. Pierce Brosnan had to go through this twice, back around the time that Gilda Radner died with his wife, and then much later in 2013 when his daughter died of ovarian cancer as well. We still don't have good screening tools. Advanced stage diagnosis is still very common. Surgery is still pretty intense and brutal in most centers. But the good news is that we have new genetic testing tools well beyond BRCA, more and better surgical options, many more chemotherapy options, new molecular targeted therapies, which we'll talk about. And the focus on prevention and holistic integrative support has increased, especially as we understand the disease more. So more are living longer and thriving. So what about the cause? Well, in 1971, the theory of incessant ovulation came to be, and the concept was that look, if you ovulate every month, there's trauma to the surface of the ovary. This is inflammatory. It causes reactive oxygen species. It causes inflammation. It contributes to cancer, as inflammation does in general. So prevention strategies included and still include oral contraceptives, which quiet down the surface epithelium, so less trauma from ovulation, less cancer risk. The estimate is that over 250,000 cases over the last 50 years have been prevented, and this occurs also with multiple pregnancies and lactation, basically no ovulation, so same effect. In the 20th century, we were taking both tubes and ovaries out at the time of hysterectomy in all women over 40 to 45 years of age, because there was no other way to really prevent, but obviously that led to other health issues like cardiovascular and bone health problems. And at the time, based on history only, no genetic testing, we did bilateral salping oophorectomies in high-risk patients as declared by their family history of cancer. So enter kind of a new age of genetics and genomics. Now, genetics has been around for a long time, obviously, and it's a snapshot study of genes and hereditary. What did you inherit, basically? Some kind of genes that may be beneficial or not, hair color, etc. But genomics is a little bit different. It looks deeper. It's a study of an individual's genes, including interaction between genes and the environment, which transitions to proteomics and many other related omics, metabolomics, etc., as a system of studying health and diseases. So this is all based on the fact that the human genome, the genetic code, was finally sequenced in 2003. So we have a blueprint of the human genetic sequence. And the building blocks of all this is DNA being transcribed, so to speak, to messenger RNA and being translated to protein. Basically the building blocks of life, because fats and carbs are really products of metabolism and are guided by other types of non-coding RNAs and protein enzymes and so forth. But it's really the DNA, RNA, protein that drives everything. So as far as genetic counseling and testing is concerned, this slide is not meant to read. It is meant to tell you that there is a whole lot of thought into guidelines that has gone into who should be tested and based on significant counseling. So personal history of ovarian and related cancers is certainly an indication for testing, strong family history, but testing philosophies differ. There's a focused one based on BRCA in the case of ovarian cancer, BRCA and a selected few other gene potential mutations, as well as broader panels of greater than 60 genes that look at various types of cancer, including other diseases also. So unfortunately, in a way, this is also publicly available now at around really under $400 online. This is kind of a industrial strength type of testing and not like 23andMe, but this is not really recommended because although you get a consultation online with a doctor, sort of, you really don't have a chance to ask questions and get them answered. So we do have a full complement of genetics experts to counsel and test you at St. John's, as many centers, and that's what you should really take advantage of. So what about genes and environment? Well, meet George. If you remember George Burns, or if you don't, George really had bulletproof genes. He died at 100, but he was drinking martinis starting at 5 a.m., many martinis, and 15 cigars a day. Now, you and most of us don't have bulletproof genes. Most cancers are in some way related to gene-environment interaction, and by environment I mean anything that you eat, drink, breathe, put on your body or in your body, knowingly or not. So you can't do anything about your genes. If you're lucky enough to have bulletproof genes, so to speak, great. But if not, you can, however, influence your personal environment. So George, again, had bulletproof genes, and here he's being interviewed by Johnny Carson.
Hasn't your doctor said to you, now, George, you got
My doctor is dead.
So basically, George had bulletproof genes. His doctor did not. So how does that work? Well, this is a picture of identical twins. They don't look the same. They look a little bit different. So why is that? How can this be so if these are identical twins who inherited the exact same genetic sequences? Well, this is based on epigenetics and epigenomics. So epigenetic modification can turn on good genes like cancer-suppressing genes and turn off oncogenes, which are cancer-promoting. The problem is sometimes this goes awry, but there are these little substances called histones, which can there's metabolic processes called methylation and acetylation, which cause the DNA to unwind and essentially allow itself to be replicated and mRNA transcribed, and as I said, to translation to proteins. But if it's wound tight, it is not open or turned off. So you have machinery in your body essentially that, based on food intake, toxin intake, stress even, so psychological issues can impact this, create a cascade by which methylation can occur, and this can significantly alter which genes are turned on and off. So how does this segue into our new anatomic genesis theory of ovarian carcinogenesis? Well, it turns out that the focus really went from the ovary to the fallopian tubes, where there are precancerous lesions called STIC lesions. And again, on a molecular level, there's hypermethylation going on, suppressing normal tumor suppressor genes and many mutated suppressor genes that are overexpressed. So basically these precursors drop onto the ovarian surface, and there's an interaction of some type, and eventually with more carcinogenesis, cancer occurs and metastases happen. So toxins do, again, enter this picture because of all the factors I talked about, DNA methylation being one of them. So I would suggest you look at the ewg.org website and learn about some of the toxins around you. You can't get rid of all of them. It's just not possible. However, you should make sure, for example, that Roundup weed killer is not sitting next to your peanut butter. Now, that's an exaggeration, obviously, but you get the point. So what about screening and risk reduction? There was a study in the UK that looked at a huge number of patients, greater than 200,000, at average risk for ovarian cancer, and screened with nothing versus ultrasound only versus ultrasound plus biomarkers like CA-125. And the primary outcome was death from ovarian cancer. The results of this pretty much, and some other studies, translated into the U.S. Preventive Services Task Force recommending not to screen asymptomatic women at average risk, so without genetic mutations. The reason for this is, as of 2015, they identified a possible benefit, small, if you're screened with ultrasound and CA-125, but the number needed to prevent an ovarian cancer, 641 women screened for 14 years are required to prevent one death. Now you might say, well, that may be worth it. The problem is there's another concept called number needed to harm, and although they never specifically stated what that is, out of the 640 surgeries, 441 of them had either nothing or benign findings with 4% major complication rate, including deaths. So around 20 women here got very seriously hurt, so there's significant risk of harm with questionable benefit. But we're stuck in the 90s with basic ultrasound CA-125. This picture is going to change when we get better screening tools. And what about risk-reducing surgery? That's one way to prevent ovarian cancer. So either, or mainly, by removing both the tubes and ovaries, and the arrow is pointing at a tube, or, as you'll note in a second, possibly just the tubes, is risk reducing. So the lifetime risk, as I mentioned, is about 1.5. It goes up a lot with BRCA1 or 2 mutations or Lynch syndrome, but it's distinctly uncommon to happen before age 40. Approximate timing, therefore, for risk-reducing removal of both tubes and ovaries is after childbearing is completed and a little bit later for BRCA2 mutations because they occur later, or BRCA after age 35, and a hysterectomy and BSO for Lynch syndrome at any point after childbearing is completed. So the risk reduction is significant. It's never 100% for ovarian because there's something called primary peritoneal cancer, which still can happen. And there's a 50% breast cancer risk reduction on a hormonal basis. So the newest data suggests that possibly early salpingectomy, meaning removing only the ovaries in your 30s, only the tubes in your 30s and 40s, and then delaying the oophorectomy for somewhere around 5 years, so you stave off menopause a little bit longer, is reasonable. The data is not fully matured, but all indications are that this is a reasonable strategy. I should say hysterectomy is a consideration if BRCA mutation occurs. This is debatable. The data is weak. But with a BRCA mutation, there is a type of uterine cancer that can occur. So when you do a risk-reducing salpingo oophorectomy, meaning removing the ovary also, you actually find up to almost 10% malignancies already there, and those STIC lesions, the pre-malignant ones, in 5 to 10% of cases, mostly in BRCA1 patients. This whole idea of salpingectomy alone kind of led to the concept of opportunistic salpingectomy in all patients. And this study that was done in Sweden, they looked at 250,000 women at average risk who had surgery at average age of 36, where both tubes were removed during hysterectomy or C-sections or any pelvic surgery. The results, 65% decrease in ovarian cancer cases. So substantial, and there are other studies that point to at least 30, if not 65% risk reduction as well. So it brought the American College of OBGYN to really come up with the recommendation that if fertility is no longer desired, instead of doing a tubal ligation, risk-reducing surgery, meaning you remove only the tubes, are in all patients at the time of hysterectomy, C-section, and even laparoscopic cholecystectomies, urologic procedures, colon surgery, anything. When you're in there and can access the tubes easily, they should be removed because that is, or it should be considered, and you should discuss this with patients. So this is a kind of a interesting plan, and it can significantly reduce the risk of ovarian cancer. Again, this is not going in and doing this without some other surgery plan. This is what you're in there anyway. What about non-surgical risk reduction? Well, oral contraception and also serial pregnancy and lactation, as I mentioned. Again, quiescent ovary, less trauma. Again, there's some early lesions in the fallopian tubes, but the inflammation on the ovary may still contribute. And then there's dietary intervention and toxin avoidance. There's a manuscript that's put out every so often on diet, nutrition, and physical activity by the World Cancer Research Fund and the American Institute of Cancer Research. And the main takeaways is strategy number 1 works and it's proven. Strategy number 2 is prudent but unproven, except to say that body fat reduction does seem to have a role, and this could be related, as far as cancerogenesis is concerned, to insulin growth factor, which fuels cancer growth, estrogen production. Toxins reside in your fat cells, so your body may be exposing itself to more toxins on a daily basis because there's toxins that are, again, held over in your fat cells, and possibly direct nutrient or possibly direct toxin effect, but we don't know that. Having said that, people say there's no research on cancer and nutrition. Well, that's not true. There is a increasing body of evidence, and if you look at other searches such as ketogenic diet and so forth, you find a slew of significant research, mostly animal studies, a lot of epidemiologic data, and also data from small clinical trials. But patients come to me and say, well, great, I know you know a lot about this stuff. What vitamins do I take and how much? What dose? Can I take a big dose? The answer is, look, we're not smarter than Mother Nature. And natural food really ought to be the main strategy for this. But there is, again, a very targeted way to do this to address what kind of foods you're eating, etc. But it's not like a drug. So taking a mega dose of a vitamin can actually hurt you and cause cancer. So the focus is on food. So what's next? Well, on the prevention side, screening advances, we can test, and this is already being tested now, for that hypermethylated P53, mutated, all those findings that are on the surface of the ovary and the fallopian tube can drift down through the cervix and be picked up on a pap smear-like test. That's coming. Or something like it, and something called ctDNA, which is a blood test which looks for circulating tumor DNA. At the moment, it's probably too sensitive for prime time and can pick up abnormalities when you really don't have cancer because your immune system is handling wayward bad cells that could be considered cancer by your body, but a cell at a time. So not ready for prime time, but probably coming up. Universal testing, genetic testing in childhood, being discussed, but a landmine, all sorts of landmines there in terms of ethics. So not exactly something that's anywhere near ready for prime time, but we can do this, and some people will be doing it, but it is largely considered not a good idea right now. What about the future of risk-reducing surgery? Well, today, we are able to do removal of the ovaries and tubes through several small incisions, laparoscopically or robotically. But the robotics companies are coming out with more and more minimally invasive tools. And this is something that is called a single port, which you can put through a single 2 centimeter incision, which allows a camera that is extremely flexible to look around and instruments that also are very flexible to move around and do a whole lot of intricate surgery. So advances are here, and by 2027, probably going to be miniaturized even further, and through the cervix, even in the office. I mean, anything is possible, but that's where we're headed. But what happens when prevention fails? So moving to treatment, I would encourage anyone who is facing the diagnosis to go visit nccn.org. This is kind of a think tank of guidelines through the major cancer centers throughout the country, updated very often, and a very good resource for guidelines, not cookbook recommendations, but guidelines, which form the basis of our therapeutic recommendations. So when cancer is being considered, ovarian cancer specifically, first we have to determine, well, do the cells look like cancer, ovarian cancer? How abnormal, meaning what grade is it from 1 to 3 do the cells look like under the microscope, and what stage is it? Now, this by convention is Roman numerals, but it's the same as 1, 2, 3, 4 to distinguish from the grade, though Roman numerals are used. But where is the cancer? That's the stage. Where is the cancer in the body? These staging biopsies are usually done during surgery or CT needle biopsies if it's clear that that's greater than stage 1. So in other words, you don't want to put a needle and rupture what could be a very early ovarian cancer. But if you see tumors in other parts of the belly, you can certainly biopsy that to get an answer. And surgery is basically part of the treatment and guides further treatment, but it's really stage specific. So going by stage, in stage 1A, where the ovarian cancer is pretty much on one ovary only and fertility is desired, then removing the affected ovary and fallopian tube and staging surgery, meaning lymph node biopsies and so forth, is the procedure. You leave the other tube and ovary and the uterus alone. Upstaging does occur, meaning some of those biopsies can be positive, in which case it's no longer stage 1, but that's the purpose of those biopsies. If fertility is not desired, then both ovaries and tubes are removed, hysterectomy is performed, and staging surgery is done. If The grade, again, not the stage, but what it looks like under the microscope is grade 2 or 3, then chemotherapy is administered. Minimally invasive surgery is almost always possible, and there's a 5-year survival rate of greater than 95%. Moving on to stage 1B, 1C, and 2, where it's adherent to the uterus or other pelvic organs are involved, or both sides. If fertility is still desired and it's only 1B, meaning both ovaries, or 1C1, meaning the ovary may have been ruptured during surgery, but nothing else was found, then it's possible to remove both tubes and ovaries. Staging surgery is done again to make sure of that. And the uterus is left in, can be left in vitro fertilization, so someone can carry without having a surrogate and with hormonal support and so forth. If fertility is not desired, then removing both ovaries, tubes, and uterus and staging surgery is standard. And pretty much for all situations, chemo with the main drugs, carboplatin and Taxol, is administered. Minimally invasive surgery is almost always possible, and 5-year survival is 75 to 90%, so still not bad. When you get to stage 3, however, and 3A, B, and C, 3A is microscopic, 3C is tumors that are greater than 2 centimeters, and involving areas like the omentum, intestines, implants on there in the lymph nodes. As you can see, there's omentum. Omentum is a fatty carpet that hangs off of your intestine nearby the colon, and it has a lot of tiny blood vessels, and it's a great place for tumors to take up shop basically and grow, and that's what happens. So hysterectomy, BSO, staging, debulking, meaning removing as much tumor as possible, and chemobiotherapy are standard for this. The only question is what comes first. In cytoreduction, usually a big incision is made, and again, these tumors can involve the omentum, the peritoneum, which is the internal skin lining. We use various tools to remove the tumors from all these surfaces, and as they are removed, then the incision is closed, and after potentially an ICU stay and recovery, chemo is administered, and the idea is anything that's left is beaten down to nothingness, so to speak, over several courses or several cycles of chemotherapy. Usually that's 6 if surgery is done first. Surgery was for many years done first, but it is now changing. And we'll talk about the details of that in a bit, but the chemotherapy is almost always intravenous, no matter when it's administered, and sometimes intraperitoneal, but that's controversial, and we'll talk about that a little bit also. After that, and towards the end of the chemotherapy, biotherapy with medications such as bevacizumab, which is something that prevents blood vessel formation, to tumors, is also administered and then used as a maintenance therapy for at least a year after the chemotherapy. And PARP inhibitors, which are used if someone does have a mutation in the BRCA gene or something else called HRD, which is a broader spectrum of abnormalities like the BRCA mutation. So minimally invasive surgery is selectively possible, and 5-year survival rate is closer to 25 to 40% here. When you get to stage 4A and B, 4A being fluid around the lungs with cancer cells floating in it, or 4B meaning tumors inside organs like the liver or spleen or the lung. Usually neoadjuvant chemo is done first, meaning chemo first, then surgery, then more chemotherapy. But 4A outcomes may equal stage 3C outcomes. So in other words, if it's only cells floating around in the lung area, then around the lungs, then the outcomes can be decent relative to stage 4. But 4B may never get to surgery because it really is very bioaggressive. Lung and liver resection is possible, but you have to look at the whole patient and see if it's reasonable to do that. And there are alternatives like freezing or microwaving some of these tumors if they're in the liver, and rarely focused stereotactic, very focused radiation. Minimally invasive surgery is selectively possible, but very rare. And again, overall, stage 4 is 5, closer to 5, and up to 15% when you get into 4A. summary of the current ovarian cancer treatment timeline is here. So the surgeon, as you can see there, is holding back the liver and the diaphragm is chock full of tumor. That's the stage, bad stage 3. And again, the problem is I'm going to focus on that kind of a tumor. So late diagnosis, so staging, primary cytoreduction or debulking, or possibly cytoreduction after 3 to 4 cycles of chemo first, then possibly maintenance therapy. The remission is usually at least 6 months in most cases, sometimes a few years. The 10-year cure rate for this is 25 to 30%. But most of the time, after watching and waiting with CA-125s, the recurrence is inevitable in 80%. And then salvage, quote unquote, chemotherapy is given, meaning other types of chemo. We'll get into the details of that in a bit. Several times, maybe 4 times, maybe more, maybe less, possible clinical trials, supportive care. And unfortunately, when that fails, there's only so much somebody can tolerate, and the tumors become resistant, death occurs. So one of the cornerstones, obviously, of the treatment is surgery. So how do we know that cytoreduction actually works, or debulking? This gentleman here, Dr. Meigs, was actually a general surgeon by training who devoted his professional life to fighting gynecologic cancer. His initial feeling was, this is a hopeless disease. You look inside and there's cancer all over the place, with a 16% 5-year survival back in the 30s was when he compiled his initial experience. But he discovered that cytoreduction and removing at least half the tumor was beneficial, and he got folks up to 27% 5-year survival. This is decades before chemotherapy was even invented. So we know beyond that while the old days where 2 centimeters or more resulted in, again, survival rates in the 20% range, if you can get down to microscopic disease, you can actually get above that red line, which is a 50% 5-year survival rate. The main takeaways is in the 30s, the goal was just to take as much as you could, maybe 50%. But then over the years and the decades, we were able to determine that it's better for you to get out more. It's worth the time and effort. And we got better at doing it. So today's goal is microscopic residual. So the question about surgery versus chemo first, at the end of the day, chemotherapy has to work, or the surgery is basically useless with all risk and no benefit. So there is a reason to consider the chemo first as a way to test the bioaggressiveness and see if it's chemo-resistant or not. And when we compared studies, this doctor here, Dr. Vergote from Italy, started this movement in the 80s and 90s, looked at the primary debulking surgery, which is PDS, versus neoadjuvant chemotherapy. You see that the survival curves are almost identical. And he published those results, and there are a number of other so-called non-inferiority trials of neoadjuvant chemotherapy, which show the same result, and there's one more maturing, which we won't know until 2024, that was done in Germany and Europe. But compelling data that it's worth considering doing this versus surgery up front. So why? What are the pros for chemo first versus surgery first? Well, as I mentioned, test to make sure the chemo works. It dries up ascites pretty quickly. With surgery, you can get rid of all the ascites, but it comes back in about a few days to a week. So drying up with chemo, it dries up within a cycle or so. The chance to improve preoperative nutrition, because most folks are nutritionally depleted by the time they've been walking around with these symptoms for a number of months. And with interval surgery, meaning after chemo, there's 25% lower risk of bowel surgery and waking up with a colostomy, fewer major complications, much less ICU need, greater chance to get to the microscopic residual, which is our target, and a greater chance to do this using minimally invasive surgery. On the pro-surgery side first, there are some selected patients that still may benefit with small volume disease, younger, good nutritional performance status. So if we think we can remove all the tumor up front, it is a reasonable goal to do that. But the other thing is that theoretically, you can avoid making some of the cancer cells resistant to chemo by doing the surgery first. But this concept, although theoretical, has never been proven, and neoadjuvant non-inferiority, again, the trials that I pointed at argue against this, so probably not an issue. So which chemotherapy do we use, no matter when it's actually given? Again, this list is not for necessarily reading on the slide, but just so you understand that it's well worked out as to which drugs are most useful, and most common is intravenous carboplatin and Taxol, usually with Avastin towards the end, and as maintenance with Avastin or PARP inhibitors, or both, which is the latest data. Assuming that there, again, is a BRCA or HRD finding. So variations of this are every 3-week dosing, which is the standard, versus dose dense, where you get one of the drugs every week, intraperitoneal chemo, which we'll touch on in a minute, and elderly adjustments, where you can actually reduce the doses of some of the chemo or use single agent with pretty good results. Well, what about intraperitoneal chemo? In 2006, a big splash, and based on a great idea. Look, give the chemo directly into the peritoneal cavity where the tumor cells are, and they showed in this study 16-month survival advantage over intravenous chemo. So this was highly touted and seemed miraculous, but it's not widely accepted in the United States still, and is rarely used in Europe because at this point it's plain old data. We've moved on a lot. Survival advantage for patients that did get that persists. So in other words, compared to using the old school intravenous chemotherapy, intraperitoneal did give an advantage. But we all know that we really can't get all of the chemo to all the cancer cells intraperitoneally anyway because of scarring and adhesions. So mostly it could be that it just gets absorbed into the venous system and it gets to the cancer cells through the veins anyway. It's possible that the benefit was dose density. In other words, it wasn't related to how it was given, but the differences in the doses that were administered, IP versus intravenous. It's unproven in an outpatient setting, which is the way people are trying to do it these days. Those are who are proponents. And IP catheter migrations, such as into the bowel, significant complications are not uncommon. And then there's GOG 252, which basically looked at this and said, well, compared to dose-dense Taxol, which is, again, the newer way of giving more intense chemotherapy, there's no advantage. But the equalizer may or may not have been the Avastin, again, a newer therapy that may have equalized the intraperitoneal versus intravenous therapies. So, but in general, what I meant by old data, and we've moved on, is that really you can't use old data and not reconcile against the very many new tools that we have today. It's very difficult to compare that and say that using that it would have been better compared to less complications, intravenous, and the newer therapies. What about treatment for recurrence? Again, a long list, but there's a separation between platinum sensitive and platinum resistant. So the main takeaways here are that if it's greater than 6 to 12 months and removable or resectable, then surgery may be considered. But if chemo recurrence is greater than 6 months and it's called platinum sensitive, then you get the same combination with platinum again, or platinum based. And if it's platinum resistant, meaning that the recurrence occurred before 6 months, then the salvage chemo list is used, and there's quite a few drugs that are available to use sequentially against ovarian cancer. Also, something we're going to touch on is if tumor NCCN guidelines, really, tumor molecular testing was not previously done, then it should be done. So moving forward, and ovarian cancer innovation and exploring really the alternatives based on innovation that we have today. Intraperitoneal chemo, as I mentioned, kind of old school, but still used. But the new wrinkle is heated intraperitoneal chemotherapy. And that is a one-time during surgery procedure. You don't leave a catheter in, so there's not a problem with bowel migration getting into the bowel. And the benefit is significant, from 34 to 46 months, so a 12-month advantage. How it works is the heat allows deeper chemo penetration, so that makes sense. And this can be used for primary or for recurrence in selected cases. What about surgical advances? Well, now we're able to do minimally invasive cytoreduction for even advanced disease. There's a handful of us internationally, really, that are doing this, literally a handful, but it has been published a number of times at this point, and it really requires next level surgical skills, but the end goal is the same: microscopic disease. And you're using far better technology such as 3D vision, magnified wristed instruments that move like little human hands. The benefits are no huge incision, lower complications, much shorter stay in the hospital, like 1 to 2 days versus a week to 10 days. Faster back to the rest of the chemo you need. If reoperation is needed, it's easier. And it plays well with HIPEC in that it's easier to less morbidity when you give HIPEC with robotic cytoreduction through small incisions. So the theoretical con is no randomized clinical trials, but then again, there never were any for cytoreduction anyway. So again, it's just a tool, and if you can get to microscopic disease, then it is certainly a way to get you recovered much faster. Instead of what you see on the left there with big incisions, usually the big vertical one, we've moved on to minimally invasive. And the video that's playing kind of gives you an idea of robotic surgery, small incisions. The instruments are wristed. The surgeon controls them and is able to do very, very intricate surgery through these instruments and essentially limit the incisionage and therefore complications on the patient. 90% of our cases, in our experience, get down to very minimal residual, microscopic to 2 or so millimeters. So it is really very, very feasible. Now, if you're not sure whether you want to do surgery first or chemo first, if there's indecision for multiple factors, there are CT and MRI scan predictive scoring systems where you could say, well, I don't think this is possible, or it is. They're not very good. So the next step is going to surgery, putting in a laparoscope and looking inside and being ready to either make an incision or going for robotic cytoreduction. But with a score of greater than 8, as judged by how much tumor there is in various places, the concept is if it's that high, then maybe you should back out and come back after chemotherapy. So it's you go to the OR, but it's another way to test. Moving forward, we're really at a point of a major paradigm shift, and that's really the genomic-based future, which is already here. We're just really beginning to incorporate this. And by that, I mean really cancer is being redefined. We're defining, at this point still, cancers by their origin, their organ of origin, like the ovary, and what cell type it is, like serous, clear cell, endometrioid, etc. But we're moving towards looking deeper under the hood. What is the root cause at the molecular level of these tumors? And is there some commonality there that can be exploited to treat these cancers that way, regardless of what organ they came from? So in the case of ovarian cancer, on the left there, all ovarian epithelial cancer patients, if you group them together, in general, pretty much get the same, within reason, chemotherapy based on those guidelines, based on large clinical trials. So they're effective therapies, but how effective? I mean, wouldn't it be nice to profile these tumors and come up with better prognostic markers, ways to determine if the treatment is going to work or not, and have a very targeted therapy for specific molecular problems or cellular breakdowns, so to speak, within cancer cells. Well, that's partly here today. We do have targeted bioagents. It at least can guide chemotherapy, what chemotherapy may work best with a specific gene mutation, etc. And clinical trials also are guided with this kind of analysis, but it's not like these are agents that are without side effects. In the future, they potentially will be less and less side effects, but for the moment, that's not the case. What we're looking for is so-called targeted driver somatic gene mutations in tumors. These are from tissue biopsies, and in ovarian cancer at least one targetable mutation or biomarker is present in 40%. So things like BRCA and the HRD I was mentioning, something called PDL1 for immunomodulation. These overlap between related and completely unrelated, anatomically unrelated cancers. Going back to the DNA to RNA to protein building blocks I was talking about, so the DNA mutation controls what proteins and controls signaling processes in these hallmarks of cancer, essentially. If you have a breakdown in all of these, then you get a cancer cell. If you don't have a breakdown in all of these hallmarks, like being able to resist cell death or something called apoptosis, or evading growth suppressors, then you can't have a cancer cell. But if you do have these, cancer is there. The good news is that we are able to target all of these with antibody blockade and anti-angiogenesis like the Avastin we talked about. The problem is that tumors are different from person to person, and they are different between the primary tumor and metastatic tumors in a patient, and they differ over time, especially when they're escaping a particular treatment. So they're moving targets. More importantly, why does ovarian cancer or any cancer recur? Conventional wisdom is that standard chemotherapy was administered and you simply didn't kill all the cancer cells. You get down you take out the tumor, give chemo down to the smallest possible volume, but over time grows back and you end up with a recurrence. Question is, will highly targeted precision oncology fare better or not? A bigger challenge is ovarian cancer stem cells. We're really getting at the root cause of occurrence and recurrence. And cancer stem cells, as the story develops here, you have a tumor, and in it are also cancer stem cells, in addition to the rapidly proliferating cells. The chemo kills them, but the cancer stem cells stay behind, and they can do nothing for a while. But the various signaling that I talked about inside of a cell eventually can activate these tumor stem cells, and you get a local recurrence. And then the tumor grows, it grows blood supply back to itself, and you have a recurrence. But it can also get into the bloodstream, go to other areas of your body, and implant there. And those cells can also just sit there and do nothing for a while. But again, the microenvironment can essentially activate these stem cells at some point, and the cancer essentially grows back, and that's how metastases form. Now, this is one of the theories of how things work, but it's certainly a viable one, and we know that this does occur. So what are we doing then to figure out if a cancer will recur or not? Well, the standard after treatment follow-up is, let's hope it stays away, go home, have a nice life, be as healthy as possible. We'll get a CA-125 here and there, CT if you have symptoms, and we'll see every 3 or 4 months. Problem with this is disempowering, and it's not very proactive. The testing is not very accurate, and we have many more options for recurrence now. So if a recurrence does occur, it's possible that we be able to do something about it. So you don't want to get to the point where you have 1 million cells, which is about the size that you see there of a marble, or billions of cells. But anyway, you get behind the 8 ball, and you're starting really from the beginning. So we now know that this has already been proven, but it's not ready for clinical use yet. ctDNA can be used to really antedate or give us an earlier indication that a cancer is recurring way before a CA125 or a CT shows tumor. So you get a recurrence where there are a few thousand cells, which may be more amenable to therapy. Now, as of yet, we do not know for sure that if you treat really early, that you're going to make somebody live longer. But the better tools we get, the more likely that's going to be the case. And it's a means to perform molecular profiling like the tissue biopsies I was talking about. So ctDNA is going to be useful for multiple reasons: for screening, through treatment monitoring and selection, through early diagnosis, detection, etc. Now, molecular integrative oncology, which I alluded to in the beginning, and overlapping with the hallmarks of cancer, it's exactly the same targets. So, proactive attention to lifestyle, nutrition, toxins, mind-body stress, you could basically, again, turn these genes on and off through lifestyle modifications, avoiding toxins, etc. A lot of these foodstuffs are immunomodulatory, anti-angiogenic. They will not replace standard therapy to get rid of cancer, but it can be potentially helpful to prevent or forestall a recurrence. At the very least, you have better quality of life and improved health. We don't have anything to epigenetically suppress cancer stem cells yet. It's coming. But for now, this is an approach, and it's free, or at least cheap. So the evolving ovarian cancer model, prevention to a greater degree, shorter symptoms, earlier biomarker diagnosis, minimally invasive surgery, genomic testing, earlier targeted therapies, which may or may not yield better cure rates. We don't know. But there is data already that if your ctDNA is positive after treatment, that there's higher chance of recurrence. So biotherapy is more indicated. If it's negative, then diet and exercise may be reasonable. But at the very least, you could certainly add it, and it is potentially helpful. With ctDNA follow-up, we may be able to get earlier and, who knows, lower recurrence, additional genomic testing. Between basically, as I mentioned before, you have to keep repeating this because tumors evolve. Maybe decrease death. Again, this is an evolving model, but shrouded in prevention, survivorship, natural integrative support, lifestyle changes, even energy medicine, essentially all the things that I was kind of alluding to that could also improve your health and possibly forestall recurrence. Now, speaking of integrative oncology, what it means is the best of mainstream and natural healing, but there's a whole lot of terms out there and it's very confusing. Basically, this is not alternative medicine, which is code for it doesn't work. And there's a lot of quacks out there, so you have to be careful. However, there's a lot to be said for natural support. And our view at St. John's is that you treat the whole person, individual patient, with the standard therapies, research, surgery, nutrigenomics, the lifestyle modifications, attention to mind, body, spiritual, social, etc. So that's it. Thank you very much. I'd like to acknowledge my teams, and certainly Lisa Stern, who is my physician's assistant that I work with very closely, our genetics team headed up by Dr. Gordon, and our medical oncology team that I work with closely. As far as the integrative medicine parts, when you come see me as a patient, you get a book complimentary, free, and essentially that asterisk, again, kind of talks about what it is, which is the integrative side. Fighting cancer, thriving in remission, or avoiding getting cancer in the first place with molecular integrative oncology, precision nutrition, minimally invasive surgery, and holistic care strategies.